So, good morning, good afternoon, good evening, wherever you are in the world. Thank you for joining us today for our Alopecia Awareness series. This was in marking of September, which is our Alopecia Awareness Month. And so we are glad to be joined by our speakers today. I don't know if you managed to join the various panels and sessions that we had today, but they'll still be live on YouTube, so you can catch up on them. So I'll just go ahead and introduce GLODERM. We are hosted by GLODERM Trainee Committee, which is the International Alliance for the Global Health Dermatology, and it is part of the IFD, International Federation for Dermatology. It promotes knowledge equity by improving access to education for dermatology trainees across the world, and we aim to provide educational events and opportunities to build networks and collaborate. So as part of our meeting etiquette today, your audio will be muted and your cameras will be turned off for the duration of this webinar. If you have any questions or comments, please submit via the chat function or the Q&A button. Or if you are joining us via YouTube, you can submit on the chat box on YouTube. Our meeting host will share this with the speakers to ensure that the speakers answer them by the end of the webinar. We'll also be sharing further information about GLODERM Trainee Committee in the chat function. So let's go to our speakers who gladly joined us today and graciously so. I'll start by giving some biographies for our speaker. So let's start with Dr. Maria Hodinsky, who is a professor and vice chair of research, Department of Dermatology, Medical School, University of Minnesota. So Professor Maria is a professor in the Department of Dermatology at the University of Minnesota. She's a tenured faculty member, vice chair of research, and immediate past chair of the department, a position she supported for 23 years. Dr. Maria Hodinsky is recognized for expertise and research in hair diseases and the peripheral nervous system as it relates to hair follicle biology. She recently completed a 5-year term as a member of the Board of Directors and American Academy of Dermatology and is a member of the Board of Directors of the Scarring Alopecia Foundation. She's also a past president of the American Hair Research Society of the North, South, and Central and Association of Professors of Dermatology. She's a recipient of the Leonard Tow Humanism in Medicine Award and has over 200 publications. So we are really honored to have you with us, Dr. Maria. Thank you for joining us. The other speaker that we had for Basics of Alopecia session is senior lecturer Dr. Nkechi Ekechukwu, who is also an honorary consultant dermatologist and venereologist at Nnamdi Azikiwe University and Nnamdi Azikiwe University Teaching Hospital, Newe, Anambra State, Nigeria. She's a visiting scholar at the School of Medicine and Allied Health Sciences, University of Gambia, Banjul. So Dr. Nkechi is a senior lecturer in internal medicine at Nnamdi Azikiwe University, Nigeria, and a consultant dermatologist and venereologist at Nnamdi Azikiwe University Teaching Hospital. She also serves as a visiting lecturer in dermatology at the School of Medicine and Allied Health Sciences, University of Gambia, where she contributes to clinical services, student training, and community skin health outreach. Dr. Nkechi holds a fellowship in dermatology and venereology from the National Postgraduate Medical College of Nigeria and advanced subspecialty training in trichoscopy from the Medical University of Warsaw, Poland. Her work focuses on hair and scalp disorders in individuals with skin of color, and she has extensive research and publications on both scarring and non-scarring alopecias, trichoscopic features of hair diseases in Afro-textured hair, and indigenous hair care practices in Africa. She's a member of the International Trichoscopy Society and the International Dermoscopy Society, Imaging in Skin of Color Task Force. And if you joined the webinar earlier, you saw the quality of photos we got from the Imaging in Skin of Color. Her scholarship includes co-authoring textbook chapters on alopecias and trichoscopy in major dermatology reference works and publishing multi-center studies on hair disorders in dark skin phototypes. So welcome as well, Dr.
Thank you so much. Thank you.
Okay. The next speaker who has gladly joined us today is a guest speaker with us, Dr. Gary Linkov. He's a dual Ivy League educated facial plastic surgeon, a native of New York, and he graduated as a salutatorian from Cornell University with a focus on psychology. Before, during, and after his undergraduate years, Dr. Lincoln pursued advanced art training in painting, sketching, and sculpture, including a 6-week scholarship program in Florence, Italy, at the Lorenzo de' Medici Italian International Institute. He then received his medical degree at Columbia University College of Physicians and Surgeons, which was the first medical school to award the Doctor of Medicine degree in the United States, and is consistently ranked one of the top medical schools in the country. During medical school, Dr. Lincoln received funding to conduct advanced head and neck cancer research at the world-renowned Memorial Sloan Kettering Cancer Center, which has been ranked as the best hospital for cancer care for the past 25 years by U.S. News and World Report. He also volunteered as an art therapist for Wilma Studio and ran his school Smile Train chapter to help children with cleft lip and palates. Dr. Linkoff then completed his residency training in head and neck surgery at the Temple Head and Neck Institute, including Fox Chase Cancer Center in Philadelphia. He served as chief president in his final year. His mentors included leaders in the field of facial reconstructive surgery and oculoplastic surgery. Then, after residency, Dr. Linkoff completed an accredited American Academy of Facial Plastic and Reconstructive Surgery Fellowship at the highly regarded Washington University of St. Louis, where he served as clinical instructor. During fellowship, he had the privilege of running a facial plastic surgery service at the St. Louis Veteran Affairs Hospital, where he performed reconstructive facial surgery for our veterans in need. Dr. Linkov has also had advanced training in cutting-edge hair transplant surgery, and he worked in prestigious Foundation of Hair Restoration as a hair transplant surgeon. He has also served as the director of Women's Center for Hair Loss in New York City. And if you know him from online, then you've also seen his works in advocacy, especially when it relates to alopecia and alopecia areata. So thank you for joining us, Dr. Linkov.
Pleasure to be here with all of you. Thank you.
Then we also have the honorable pleasure of being joined by Professor Nkoza Glover. So it is an honor to have you today here, Professor Nkoza. So if you haven't heard about her, she hails from Durban, South Africa, and lives and works at the Nelson R. Mandela School of Medicine as the chair and professor of dermatology, as well as the dean and head of School of Medicine at the University of KwaZulu-Natal, Durban, South Africa. She's the female dean among the 10 medical school deans and one of the first African female dermatologists in South Africa. She has since trained and mentored over 40 dermatologists, many of whom have started and are heading well-established, successful public skin clinics, many research interests, and her PhD focus is on ethnic skin and hair, as well as HIV and skin. She's a National Research Foundation rated researcher with more than 85 scientific publications in peer-reviewed journals, as well as more than 15 chapters in international dermatology textbooks and 2 dermatology books, which depict and are relevant to South Africans and Black skin. She is a member of numerous international dermatology boards and societies, including the Global Psoriasis Atlas, International Eczema Society, Skin of Color Society in the USA, as well as many others. She is an advocate for diversity and inclusion in our societies. So thank you for joining us, Professor Nkoza. We are also joined by Dr. Maria Miteva, who is a professor at the Philip Frost Department of Dermatology and Cutaneous Surgery, University of Miami, Miller School of Medicine in Miami, Florida. So Dr. Maria Miteva is a professor at the Dr. Philip Frost Department of Dermatology and Cutaneous Surgery, Florida, and she's a dermatologist and dermatopathologist with special expertise in hair disorders, hair pathology, and trichoscopy. She's the author of several books, including the first book dedicated to correlating trichoscopy with pathology entitled Hair Pathology with Trichoscopic Correlations, which we enjoyed during your session today. Numerous scientific publications, including 4 CME articles on alopecia and hair pathology, and many book chapters. She's on the editorial board of several peer-reviewed journals, including the Journal of American Academy of Dermatology. In recognition of her teaching expertise and excellence, she was awarded the inaugural Best Faculty Educator Award by the Faculty School of University of Miami, and Best Teacher Award by the residents at the Department of Dermatology for several consequent years. It's an honor to have you, Prof.
Thank you for having me.
We also recognize the presence of our chair, Dr. Caroline Warnat, who has graciously joined us today. So as we begin this session today, thank you all for sparing the time. I'd like for us to begin with some questions. So I'll start with the questions directed at the presenters for Basics of Alopecia sessions. So let's start with Dr. Maria Hodinsky. Given your expertise in inflammatory autoimmune disorders of the scalp, how do you approach treatment when a patient presents with overlapping features of scarring and non-scarring alopecia?
So that's a great question. To just repeat that, can you hear me okay? Because Karen, you're a little soft. It's a little, yeah. So,
Okay.
so the question is, how does one approach a patient who has both scarring and non-scarring alopecia? I think you have to treat both conditions, and some of the tools that we have will treat both conditions. So for the inflammatory cicatricial alopecia, one has to jump in right away and treat aggressively and reduce inflammation and get the disease under control. And then when one starts to work on hair regrowth, say, for example, using topical or low dose oral minoxidil or photobiomodulation or whatever, or PRP or whatever you like to use to regrow hair, those treatments will impact the non-scarring alopecia positively. And if the scarring alopecia is under good control, then one has the possibility of regrowing hair as well. So that would be my approach.
Thank you, Doc. Next up for Dr. Nkechi. In your clinical practice, what strategies have been most effective for improving adherence to long-term alopecia treatment plans, particularly among younger patients?
Okay, thank you. That's also a very excellent question. As we all know, it's really very challenging and difficult to have the young patients adhere because they are usually very impatient. They want the clinical process to, the healing to be faster, the treatment to work faster. But I find out that by the time you educate them on the condition that they have. For instance, if it's a non-scarring alopecia, of course, it's a little bit more hopeful. But for the non-scarring types, you have to, in a very compassionate manner, you have to explain, you have to be realistic to tell them that this is the situation at hand, and then the treatment would actually help to halt the disease process. So that's one of the ways I find it's usually helpful. Then also trichoscopy helps because it helps to show even very little progress. When you have little progress in the treatment and you show them using trichoscopy, they're actually very much encouraged to continue with their treatment process. Then also explaining to them that not being regular with their drugs or their medications can actually worsen the whole process and also retard the progress. So I think that's also enough stimulation. Unfortunately, we don't have patient support groups in my part of the world, but I know that patient support groups are actually very good help to improving when they see other patients who have had similar conditions and have taken their drugs and adhered to their medications and other non-drug therapies, and they've seen positive results. So it's actually very helpful. So these are some of the things that we use. But first of all, you need to educate the patient on the condition, what has caused this, what has triggered it, and the need for the treatment, whether it's non-drug or non or drug. And then expectations has to be addressed. So they have to be realistic with the expectations.
Thank you. Moving on to Dr. Gary Lincoln. How do you approach counseling patients who may not be ideal candidates for hair transplantation but are seeking restorative solutions for their hair loss?
Yeah, I mean, I think it also comes down to patient expectations. I think most people, have enough donor supply. I mean, I don't. I have areata. But, most people are coming to me and, they have some hair to give. And it's just a matter of like, is there enough for what their goals are, what their expectations are? And of course, they need to be healthy enough, and we need good stability of hair before doing surgery. But I find that most people, maybe they're not candidates right when they see me initially because they're not on any medical therapy and they're, actively losing hair, but we can typically stabilize them and, do something surgically to improve the situation. But, some people don't want surgery. Uh, some people don't want to do any medical therapy. And so, we don't deem them a great candidate most of the time if they're unwilling to do any medical therapy at all. Uh, but most people are reasonable and they're asking for help, they're looking for advice, they're willing to work with us to make things better. And when the time is right, we do a surgery or sometimes several to try to meet their needs. And I think the more I've been doing this, the better I can set the expectation. I don't think I was as good at that when I first started. But and also like as our gallery grows, like people can actually go and see examples that might be relevant for them, and we can point them in the direction of someone who has a similar situation, and that can help them give them an idea of like realistic expectations.
Thank you. Next up, Dr. Maria Miteva. So the question is, what is the optimal biopsy technique? So in terms of punch size, number of samples, and the site of selection for optimizing the yield in alopecia so that you maximize diagnostic yield.
So thank you for that question. So I usually use a 4 millimeter punch, and 4 millimeter punch is the optimal size because most of the literature and most of the data actually comes from studies done with 4 millimeter punches, which is also creates a very small defect. And I think when we consider our hair loss patients, we want to be also very cosmetically sparing. So I would do a 4 millimeter punch, usually one biopsy, depending what I'm biopsying. If my suspicion is scarring alopecia, I would use my dermatoscope to guide me where to take the site of the biopsy. And that I find very helpful. It's a very simple technique, that you can practice in the office. And I would take one biopsy. It would be very unusual for me to take two punch biopsies. That would be if I really don't know where I am, what I'm looking for. If the case is more difficult, I may take one for horizontal sections and one for vertical sections. And only probably in frontal fibrosing alopecia, I'd like to take a 3 millimeter punch biopsy. So I know that the defect with it heals very well, the hairline, by the way. But I would take a 3 millimeter punch biopsy, again, using the dermatoscope to select the optimal site. So in non-scarring alopecia, in summary, I would take one 4 millimeter punch biopsy and send it for horizontal sections. If the pathologist you're working with is familiar with that, that would be the best approach. And if you really don't know, if you suspect something really extraordinary like sarcoidosis, rare things on the scalp, or lichen simplex chronicus, I may take one for horizontal and one for vertical sections.
Okay, thank you so much. For Professor Nkoza Dloba, I hope you can hear me. From your experience in undeserved communities, what are the key barriers to diagnosis and treatment of alopecia, and how can international collaborations help address them?
Hi, Karen, and hi, colleagues Maria, Gary, Getchi, and Vashita. I'm so sorry you can't see me. My video is not working. But thank you so much for coming. I know, when I approached you guys, we're more than happy to join the GLODERM platform. And we really appreciate you giving us your time and sharing your expertise with the young dermatologists all over the world. Thank you for that. We know how busy and hectic your lives are. So back to your question, Karen, do I still remember what was the first question? You had three questions in your question. I think the first one, can you just say them again one by one?
From your experience in undeserved communities, what are the key barriers to diagnosis and treatment of alopecia, and how can international collaborations help address them?
Okay. I think undeserved community and the barriers. I think firstly, the knowledge of hair loss disorders is challenging, both amongst dermatologists themselves, because, I think during our undergraduate training, there was not much focus on alopecia and hair disorders. And I think at times it's when one develops an interest in the area, and that applies to me as well, that, one had to develop sort of an experience and expertise. So I think it's important for us, for example, to share our knowledge with the primary healthcare physicians. And I think one of the things that we do here in I think in Africa and South Africa, I'm sure other places as well, is to have a GP update, general practitioners update, on an annual basis, where we talk to them and teach them the common hair conditions and the new ones that have developed. And then that way, at least they are able to diagnose and refer the patients immediately, because we all know that with hair disorders and hair loss, it's important that diagnosis is made early, particularly with the scarring alopecias, and the patient can be referred timeously. And then in terms of treatment, that's a challenge as well, because working in the public sector, most of the medication in the public sector in our governments, we don't have minoxidil, we don't have oral minoxidil, we don't have biologics, we don't have topical treatments. Literally, we don't have much to treat the scarring alopecias, particularly. Even things like calcium urine inhibitors, you have to motivate for that. So it's a bit of a challenge for low and middle income countries, as well as working in the public sector, because these drugs are unaffordable. And for hair, we really don't have much at our disposal in terms of treatment. In terms of what can global health do, I think it's really trying all the time to empower our colleagues who are not dermatologists and continue to share expertise, as we are doing right now, getting experts in the field globally and internationally to create awareness about hair loss, because they affect the quality of life and stigmatize patients. And again, platforms like this, like GLODERM, are really crucial for us to spread the word about the hair loss conditions. I hope I answered your question in a long way around.
Okay, can I add something? A little something to, yes, Prof has really said it all. But I just want to add that in addition to what she has said, we don't have dermatopathologists that are very experienced with scalp biopsies in Africa. Well, I don't know about other parts of Africa, but I know in Nigeria and in the Gambia, we don't have those dermatopathologists. So it's really a challenge. And then most of our patients find it very difficult to accept scalp biopsies. I don't know why. Maybe in Africa, people hold their hair is really of very importance to it. They have cultural, religious, and traditional beliefs to their scalp and their hair. So I remember a patient I had that I really convinced her to get a scalp biopsy. And when we did that, the result came out to be actinic keratosis. And I'm like, what? So it was like it was really difficult to die, because I was suspecting an LPP in this patient, and it was nothing anything near actinic keratosis. So the expertise in the histopathologic analysis of scalp biopsies, the acceptance, and then finally trichoscopy, which is actually a very important tool, non-invasive tool to make diagnosis even without having to do a scalp biopsies. The dermoscope is very expensive. So there are very few dermatologists that can afford the dermatoscope. So these are all the challenges we have. And there's also not much training on trichoscopy in Africa, in the underserved communities like Africa. So Prof has really said it all. Just this issue of infrastructural absence and all of that. So thank you.
Yeah, in fact, Ngechi, sorry, Karen, let me jump in. Thank you so much for mentioning those two. Very, very crucial. I don't know how I forgot that. Like right now with Maria, then most of the time, sometimes I have to send some pictures to Maria, Professor Miteva, to assist me with the histopathology, because right now in South Africa, for example, we don't have a derm pathologist. Nothing in the whole country of 60 million people. So we are really trying to see if we can start with some online courses. And again, mentioning the trichoscopy, Maria mentioned how important it is to do a dermatoscope directed biopsy. Otherwise, it's a waste of time and you miss the diagnosis. So if we can't afford that dermatoscope, which is so expensive, how do we get to do that? Thank you so much for adding to what I had mentioned. It was really crucial. Thank you.
I would like to just add a comment. So some of my patients go to Amazon and they can buy a device. It's not a dermatoscope, but they come to clinic with pictures of their scalp. And the pictures are actually very good. And they show many of the features you can see with the dermatoscope. So when they buy it here, it translates, I think, to like 30 US dollars. So it's not a dermatoscope, but it is very useful as a tool. And so we've been looking at comparing, what do you see with the dermatoscope and these devices that people can actually buy online. So just something to think of if there is a barrier to getting a way to magnify the scalp and actually look carefully at the hair follicle and inflammation. There are AI tools that are coming out.
Thanks, Maria. It's very helpful to know about as well, because we have to find other ways of mitigating some of these challenges that we have in low and middle income countries. Thank you.
Thank you.
I want to mention, Nkosa, hi, and hi, everyone. I also want to say that I'm very happy to always look at hair biopsies. They're not easy, but with time, they do become easier for pathologists, and I'm happy to participate in any online initiative that we can organize. That.
Oh, that's amazing. Thanks, Maria. In fact, just to add, now we're working, there's a colleague of mine from the UK and another one from Harvard. We're trying to see if we can have online courses every year. So I will definitely invite you to be part of those dermatologists who are keen to outreach to us in terms of empowerment and democratization of knowledge and education. Thank you for that.
Thank you.
Maybe while you're still on the topic, there was a question that was directed at Professor Litem, but he's not able to join us, but it's relevant to what we're discussing. A trainee asked, she was wondering how she can improve her dermoscopy skills, especially now that she's in training. And she had found the session on trichoscopy very informative. So I don't know if you have any tips. It's an open question to anyone.
Okay, let me jump in there because I was lucky to have gotten scholarship from International Society of Dermatology. So I had an experience in Warsaw, Poland. So I had to learn a lot of trichoscopy under Professor Rudniska. I find out that getting the textbooks, because most of the patients I saw in Warsaw were actually Caucasian patients. So had to translate what I was seeing in the scalp hair of Caucasians to that in the Afro textured hair. But now there are textbooks that have been written on specifically for Afro textured hair, and more are still coming up. So if they can lay their hands on those textbooks, it can also help to add to what they have. But I know there are also very fantastic textbooks written even on Caucasian hair that you can actually, when you do that, you can also try to match it with what is seen in the Afro texture there. So they're out there in the literature. There are books, there are articles. I know Prof. Glover published an article recently on trichoscopic features of the Afro textured hair, the measurable parameters. So there are out there. There are also webinars. There are seminars online that can also help. And I think that's basic. And then you have to do it, because when I came back from Warsaw, it was a bit challenging translating what I saw with what I was seeing in Afro texture there. But when you keep seeing the patients, when you look at it, you go back, you ask questions, you send pictures to colleagues who are very good in trichoscopy, then they can also guide you on how to make a diagnosis out of what you're seeing on the real patient. Thank you.
I think there are some very good textbooks, like you mentioned. So Dr. Tosti from Miami, Maria, you might want to talk about that a little bit. Isabella Doce, Doche, published one of the first textbooks. Isabella practices in Sao Paulo. And I think in her book too, there's more variety in terms of scalp color and such, and different hair types. They're excellent textbooks. I completely agree with you. I can't hear you.
Dr. Miteva, we can't hear you. Now
I
we
don't
can.
know why. Now you can. No, nothing to add. I think Dr. Hurdinsky just pointed out, there's a lot of great books, and I think what I would agree what helped me the most is practice every day. You have to practice, you have to go back, you read the textbooks, and there's a lot of PubMed articles, but a lot of it comes with practice. And you observe something that you haven't seen, go back and study it. I think that's the way.
Thank you. Okay. So let's go to our next series of questions. Alopecia areata was quite a common theme in the questions. So let's start with Dr. Maria Hodinsky. What are the most promising emerging therapies for alopecia areata and other immune-mediated hair disorders? And how close are they to routine clinical use?
So right now in the world, we have Janus kinase inhibitors present in most parts of the world. And in some parts of the world, the JAK inhibitors or Janus kinase inhibitors are readily available to the patient with alopecia areata. In other parts of the world, in some countries, the Janus kinase inhibitors are available, but the disease is still considered cosmetic, and the patient has to pay thousands of dollars. I'll use dollars here, many dollars in order to get the medication. So there is a disparity with access to these JAK inhibitors. And in some countries, and based on what I'm learning here, the JAK inhibitors are probably not even available. We have topical JAKs that are also available. Most of those are still not well studied in alopecia areata. The studies that have been done did not really show a lot of efficacy. We still have emerging therapies too. We have new medications that are in clinical trials. And currently, there is a study also going on in 2 parts of the world that I'm aware of, maybe even 3, to look at a gut transplantation or changing the microbiome of the GI system to see what will happen in the skin, and in particular here in alopecia areata. Our traditional therapies are still, they still work for many people. And again, methotrexate will be one medication that if you have to go to a systemic medication is probably available in most parts of the world. Most parts of the world will have topical steroids. They can still work in limited patchy disease. And then in some countries, we can use intralesional steroids, and in other countries, people are not able to do that. So we have this very broad way of treating alopecia areata, and in every country, people have figured out what to do. But for patients with extensive disease, this new horizon with Janus kinase inhibitors is the era that we're in right now.
Oh, thank you. So as a follow-up question, and I'll direct this at Dr. Nkechi, do you frequently encounter secondary tinea capitis in patients who you're managing for alopecia areata with either topical or oral steroids?
Okay, that's a very excellent question. Actually, I haven't had a patient with alopecia areata that developed tinea capitis, but I've had patients with psoriasis and discoid lupus. In fact, the patient with psoriasis was quite an interesting case. We're managing her with methotrexate. She had scalp and then skin chronic plaque psoriasis. So she did very well. Her skin lesions did, she performed very well on methotrexate, but the scalp lesions were actually persistent. So she had these scales on her scalp, and I just used the demoscope to look at it. And interestingly, there were zigzag hairs, there were the Moscow hairs, and I'm like, wow. So and she had actually been using potent topical steroids on her scalp. So I've seen that. Then also a patient I saw in the Gambia, she had discoid lupus erythematosus on the scalp. For her, I hadn't started treating her. It was just at the first contact with her, and I used my demoscope. Of course, she had features of discoid lupus, but she had corkscrew hair, she had comma hair. So I wasn't so sure if those were because she had used, because it's a very common practice in African settings for people to use topical steroids, potent topical steroids for any skin lesion. So I wasn't so sure if she had used it because we had communication issues. But I've had, yes, tinea capitis co-occurring with discoid lupus and psoriasis, but not with alopecia areata.
In the same line of treatments for Dr. Linkov, are there advances in transplant techniques or adjuvant therapies that you believe will significantly expand in the next 5 to 10 years for patients?
For areata specifically?
Or in general?
Oh, in general. Well, there are some like specific kind of surgical tools that even like I'm starting to work on in my practice to try to improve FUE surgery. FUE surgery is now a little bit more of the state of the art, I guess you could call it, for harvesting hair. I mean, FUT still works really well. It's just a lot of people are looking to avoid like a linear scar. So FUE's been around for, it's probably been mainstream for at least 10 years. But I think there's ways of making it even better because you still get these little dot scars, and even with smaller punches, you can't go too small, or else like you don't capture your larger groupings of hair, the grafts with like 3 and 4 hairs. So that's the tricky thing about these cylindrical punch designs. So I'm actually starting very early in this project, but we just teamed up with an engineering team to try to create a new type of device. So I think there's room for improvement on like the tech for the basic steps of hair transplant surgery, and then maybe eventually creating a robotic system that's actually good, because the current one is not very good. The Artist robot has a lot of issues. It's not like a patient-centric device. So, if we actually make it better for patients at every, stage, and then eventually make it more automated, that would be cool. Uh, so that's the way I see it on the surgical front. I mean, cloning is like, I think we always say a couple of years away, but I don't think that that's happening anytime soon. I think the problem with cloning, the way I see it, because there was a company that was doing a lot of like mouse studies out from California, and then they kind of just like ran out of money. It's really expensive to even get to a human trial, and then to, like do a human trial, and then you have to do it for years, ideally, to make sure that the hair continues to grow and cycle. Uh, so I don't know if like a company will be able to raise enough money to really even test that, or to get to the point of testing that. And then who's going to be able to afford those types of procedures? And they're going to be so expensive, like 500,000 more. I mean, God knows. So I don't know if that's ever going to be a reality, because like you can't count on insurance companies to pay for that. They're not going to pay for that. They don't even want to pay for finasteride, so yeah, so that's, I don't know. I don't know if the rest know of any trials happening, but I think there was supposed to be one in Japan, but that never happened for cloning. And then, tissue engineering, I guess, is maybe, I mean, that's been showing promise for decades now too, and we still are not too close to anything on that front. PP405 is a newer type of topical gel that's being tested now in clinical trials. I put out a YouTube video trying to summarize whatever we know so far. There's no peer-reviewed study on it yet. They haven't published it yet, but in my estimation, I don't think it's going to replace the important, the finasteride and dutasteride for prevention. And then on the stimulation front, which is more of it's intended for, to stimulate the stem cells, I would be surprised if it is more powerful than oral minoxidil, because that's the agent that we see the most benefit from for most patients, men and women, compared to like pretty much every other stimulating agent, especially as the dose goes up. So I don't know, like I'm hopeful for new things that are, not like the nitty-gritty surgical stuff. Um, but I don't know. I mean, we'll see. I know there's androgen receptor blockers that are being investigated. Maybe they'll be a little, safer than finasteride, dutasteride from a side effect profile. So yeah, I mean, there's always like something new being tested, but uh, nothing that I think is going to be a complete game changer from what I can tell so far. But I'm looking forward to be proven wrong, and then the surgical stuff. I mean, someone's got to push that forward, but all of this like new investigation of actual tools, I mean, that's really expensive. So we'll see how far we can get. Yeah.
Thank you. So, still on the same line of thought for Professor Nkosa, what research priorities do you see as the most urgent in tackling alopecia disparities globally?
You're asking me all these difficult questions that are not clinical.
I'll be easier on you next time.
Oh, yeah. I think we're doing well so far in terms of looking at the common conditions, hair loss conditions that are affecting that are affecting diverse groups of individuals. And I think it's always good to acknowledge the positives. And I think we're doing well also in terms of being inclusive, in terms of, guidelines that are inclusive of other marginalized demographics. And the challenges I see is in, of course, we spoke about the DEMPATH expertise that are not available to us. We spoke about these sophisticated advanced machines in terms of trichoscopies, dermatoscopes, but Maria did speak about some simplified magnifying items that can be used. So in terms of AI, I think we need to move in that direction and make sure that we're able to communicate with our colleagues internationally. We can share histology and get reports from them, even if we don't have the physical expertise in terms of human resources. But we can, through AI and technology, we are able to get advice and guidance from our international colleagues and have those equipments available to us. And then in terms of treatment, I think it's also important that treatment is made accessible. The JAK inhibitors, the biologics are very costly for us. I think 1 month's treatment for a patient is probably equal to a consultant's salary here in South Africa. So that way it makes treatment and access to these novel therapies almost impossible for us. So it would be great also to look at how can we use old drugs that we use for other treatments and now can be used for disorders of hair loss. For example, we now know that we can use low dosages of minoxidil, oral minoxidil, to treat alopecia areata and other hair conditions. So, revisiting the old drugs, chloroquine, and see whether these can be used in a cost-effective manner to treat the current hair disorders. And of course, in terms of education, I believe if we focus on education, try to find out whether there's some of the myths that patients have and try and dispel those, and also educate patients. I think in terms of skin of color patients, the issue of traction alopecia, which is the most common condition that we see, and yet it is iatrogenic, it is self-induced. It's an epidemic, but it is self-induced. So we need to focus on education the consumers and so that they know what to use and what not to use and how to manage their hair. And of course, even other groups using hair grooming products that contain formalin or endocrine disruptors. We need to be able to translate the research that we do and from bench to bedside so that we can get this information to the consumers in a manner that is simplified and take over the misinformation that is happening out there through social media, people using different things. So we need to own that space as well, because I think it starts with education and find ways of communicating effectively and simple to our consumers and patients. So targeting both patient research and well as with therapeutic aspect of hair. Thanks.
Thank you, Professor Nkoza. So my next question is to Dr. Miteva. Are there cases where histopathology is not definitive, and what should clinicians do in such situations?
That's a good question. Yes, of course, there are cases where histology is not definitive. I would start with scarring alopecia, where the histology is most helpful, is to diagnose scarring alopecia. And in that case, also I would like to mention that not just making the diagnosis, but elaborating on the features that a pathologist sees in the report are very helpful to the clinician. Like, for example, if there is significant inflammation, and then this can guide the management. But of course, there are cases where it's not definitive. And for example, if in non-scarring alopecias, okay, based on vertical sections, there will always be inconclusive, the results, because there's no way to establish a diagnosis just visualizing 3 or 4 follicles in a vertical section. So you always have to, we have to train more pathologists to be familiar with horizontal sectioning, where you increase the diagnostic yield. Many times, without the clinical context, without the clinical information, even with the right, counts and ratios, you still could be inconclusive because it could be very early, for example, androgenetic alopecia. But it could be also sometimes alopecia areata with regrowth can show, similar features. So I need to know the clinical setting. So I would say pathologist is most helpful to diagnose. It's still the golden standard to diagnose scarring alopecia. In non-scarring alopecia, could be not so helpful unless you provide very good clinical pathological correlation.
Thank you so much. My next question is an open question. We've talked a lot about JAK inhibitors and the cost. So what should be the maintenance treatment in alopecia totalis or universalis after excellent response to JAK inhibitors? Because we've consistently mentioned that recurrences are noticed in patients who stop therapy with JAK inhibitors. Anyone can take it.
I'll go ahead and start. So many patients respond to JAKs and they respond very, very well. But patients while on a JAK can also experience active hair loss. So we still have patients who are taking a JAK every single day who get active disease. And so we treat that active disease with intralesional steroids. Topical steroids are traditional ways of treating alopecia areata. But then there are patients who get 95% of their hair back and they're very, very stable for weeks or months. And the question then becomes, do we go to our old way, so to speak, of treating alopecia areata, where we treat episodes and we stop the treatment and we wait to see what happens in the next days, weeks, months, years? Or do we follow what is currently being proposed by many, that the patient has to stay on a JAK forever? But life happens and women get pregnant and they have to come off a JAK, and illness occurs and people have to come off a JAK. So we have life events that tell us that sometimes people can do quite well if they come off a JAK. But in general, the thinking currently is if you've had extensive disease and you got a great response, that you probably should stay on the medicine. But in clinical practice, we all see variations on this theme for different reasons. So those are my opinions on that question. Oh,
We can hear you, Dr. Miteva.
I'm sorry. Can you hear me now?
Yes.
I
yes.
guess I have to do it several times. I agree with Maria. We have our patients who take JAKs, they can take it continuously and they do very well, many of them. Just like in real world, they do just as well as in the literature. But there's a subset of patients who at one point they stop responding, like a 10%. And then in those patients, just like she said, we try to do topical injections, increase the minoxidil, but we don't stop the JAK. At least I don't stop it. And I try in some of the patients, for example, who take baricitinib and they are stable, have been stable for 1 year on a 4 milligram. I try to now take them down to 2 milligrams and see if they're going to be able to sustain. But when insurance coverage is not the problem, we don't stop the JAK. And this is a very important thing. You have to counsel patient from the very beginning to set the expectation right, that that's not a fast fix. They have to basically anticipate staying long-term on the medications. Very good point is I've always thought about the pregnancy. They have a registry with most JAKs now, but we do counsel patients that they must not get pregnant. So I currently have a patient who She got off the jack to get pregnant, and she has lost a lot of the hair during pregnancy. So knowing that after pregnancy she can restart. So bottom line, if you have access, you continue the medication.
Thank you. Okay. Thank you all so much. A final question, maybe one which anyone can weigh in as well. What hair care practices do you discourage that you feel impact your patient's hair loss?
I'll jump in real quick. I just have a lot of male patients who are on TRT or testosterone replacement therapy, and there's just such a direct correlation between like when they start that type of treatment and when they experience an acceleration of hair loss. So for those patients who are coming in wanting surgery, I tell them like they have to be on finasteride, for a period of time before we even, jump to surgery because like it's just that they have to counter those effects of that higher testosterone, circulating in their bloodstream. And we just see it for like every patient, even when I hear it in the story, especially when, usually people on that type of thing are not, in their 20s, or 30s. They're a little older. And when they tell me like, oh yeah, like I was pretty good until, 2, 3 years ago, and the hair loss started to accelerate. And even before they tell me, I'm like, did you start TRT? And it's almost always a yes. It's kind of interesting. So when there's a rapid acceleration, for patients who are maybe in their like 50s, 60s, it tends to be because of the TRT, which is interesting. So that's something, not that I discourage if they need it, they need it. But the requirement for finasteride goes up significantly to try to counter those effects.
I think you bring up a very good point because many women in the perimenopausal, postmenopausal period are applying topical testosterone as well as taking a topical estrogen and then an oral progesterone. So when we check their testosterone levels, they're elevated. And then it comes back to education. Our colleagues in OBGYN sometimes don't see things the same way dermatologists do. So they go, no, there's no relationship. So there is a time that needs to be spent to educate our patients that testosterone can have a negative effect on hair and to really reduce the amount that they're putting on their skin topically or even taking orally.
Interesting, yeah.
Okay, so maybe I'll just jump in there for Afro textured hair. So some of the hair care practices that we usually discourage our patients are use of tight hairstyling practices like the tight braids. Now I think it's really a genius technique that the Africans were able to design. There's this knotless braids. So it gives less traction than the regular traditional braid. So that's also another option that you can ask your patient to use rather than the traditional braids. Then the cornrows, the dreadlocks, then also chemical over processing the hair. So you discourage them from either the use of chemical hair relaxers, or if they must, they can reduce the frequency. So even the heat treatment, like the excessive blow drying, use of hot combs, which has, in as much as the link between hot combs and CCCA is neither here nor there, but we discourage all the destructive or tension hairstyling practices that they often engage in. And we encourage them to use more safer hairstyling practice, like the use of the natural hair, which has become very popular in our settings now, because the natural hair is a lot more resistant to pull than the chemically processed hair. And also use of dyes, use of bleaching or bleaching of hair. These are all practices that can actually worsen existing hair shaft problems or even scarring alopecia. So these are some of the things we discourage our patients from practicing. I know Prof has a lot of, I think she talked about wigs, hair extensions. Hair extensions are endocrine disruptors and all of that. So Prof Nkoza will have more to say about that than myself. Thank you.
Yeah, thanks, Kechi. Yeah, I think I agree with everything that you have said. But just to add that also I have, I think most of my patients who have hair loss particularly, I recommend that they stay away from any chemicals, any heat, any mechanical traction, and any form of synthetic hair. And they just need to try and keep their hair natural. And, in a retrospective study that I did, I found that those patients, in fact, if you find that their siblings who continue to braid or pull their hair or use extensions, their hair loss is much, much more progressive than those who keep their hair natural. And I always say to them, treating hair loss is like treating diabetes. You have to give them medication, whether it's insulin and oral hypoglycemics, but you also have to enhance that with the diet. So with hair, we have to treat the hair, but we also have to avoid all these things that can trigger and exacerbate more hair loss. And anecdotally, I think I've observed that those who stick to those recommendations, the hair loss is sustained and the hair progression has been halted. So that's how I did with the patients. It's difficult at times because everyone wants to put wigs and synthetic hair because it's in vogue, the social media, and so you have to really persuade them so they see that there is actually value in keeping your hair natural, particularly if you have a hair problem. Thanks.
So from my Southeast Asian colleagues, I learned that when you shampoo and your hair is wet, they actually have a special towel that they use to dry the hair. So there's patting done rather than what most people do with a towel. So you have to be careful too as to how you dry your hair, not just with the dryer, but also with the towel.
On that note as well, Maria, thanks for that. The one other thing, recommendation, because we realize that most patients, African hair with Afro-textured hair, tend to wash their hair less frequently. And that results in accumulation of hair products, the seborrhea and oiliness. And that in its own does actually cause inflammation. And we did a study here comparing patients who were washing their hair weekly and those who were washing them less frequently. And we found a very high concentration of Malasseza fever as well as bacteria in patients who were washing their hair less frequently, particularly those who are wearing hair extensions, because it's very difficult to wash your hair with thick hair extensions and wigs and weaves. So the recommendation from that study was that the optimal best way for African hair is to be washed once a week. And that way you can minimize the symptoms as well as minimize the colonization of the Malasseza as well as bacteria on the scalp, and thus minimize inflammation and seborrheic dermatitis. Thanks.
So what we've also seen is that a nice way to clean the scalp for those who don't want to shampoo, say weekly, who might want to shampoo even monthly, are these new devices that are out there. Perhaps someone else on the Zoom call here has experience with those, but they are devices basically that shoot out water and they act like a vacuum. And so the technician or the nurse uses the device along the scalp and cleans the scalp. So it's a very fast procedure. The scalp is clean, but you haven't really then dealt with the hair issue and what bothers a lot of people when they have to shampoo too frequently. So there are other ways to address that scalp health issues.
Thanks.
Thank you all very much. I'd like to appreciate all of you individually for sparing the time, the effort, sharing your knowledge and expertise with us. We really appreciate it. And on behalf of the GLODERM Trainee Committee, kindly follow us on our social media pages for any upcoming events and webinars, even for the next month. And we look forward to more lively interactions. Thank you so much.
Thank you for inviting us. Thank you, colleagues, for joining. I know I had to pull you, get you here. You could be doing other things. Maria, Kerry, Maria, both Maria and Maria, whichever, as well as Ngechi. Appreciate and thank you also to our GLODERM host for hosting us and the lovely questions that were very informative. I learned so much myself from everybody's interaction and discussions. Have a lovely evening.
You too. Thank you.